Hello and welcome to Best of the Day from the 2013 meeting of the ASCO Gastrointestinal Cancers Symposium. This is the 10th anniversary year, and it's been a very interesting meeting thus far. Today is day 2, and traditionally day 2 is cancer of the pancreas, hepatobiliary cancers, and small bowel tumors, which have been totally ignored this year. But that's okay, because we have Jordan Berlin from Vanderbilt University with us, and we're going to talk about some of the information, especially in regards to cancer of the pancreas, where there is an intense amount of both bench and clinical research going on. So Jordan, welcome to Best of the Day. Thanks so much for being with us.
Well, thank you. I also plan on ignoring small bowel cancer.
Yes, well, as Margaret Tempero did when she gave her review of the last decade.
Yes.
And did not go into that at all. But let's begin with some of the sessions that were presented this morning. And there was a talk on the metabolic syndrome, and that's a topic that we've seen presented at ASCO GU and at other national meetings with high lipids, obesity, high BMI, other, hypertension, other factors. And then the other metabolic sort of problem that was discussed was type 2 diabetes mellitus, and just what the relationship between these two entities and pancreatic cancer is. Do they increase the risk? Are they due to pancreatic cancer? What is the association, and what is your take on that situation?
First, the metabolic syndrome, the obesity epidemic in the United States, there is no question that it is associated with the increase in incidence of cancers such as pancreatic cancer, which is on the rise, partially just because we're aging, and the baby boomer population in particular is aging. But there's also this rise in obesity. I live in the southeast portion of the country, which has the largest obesity rate in the United States, and this is a huge issue. It is a cause for diabetes, and therefore the whole issue gets confounded because diabetes in and of itself has been shown people with long-term diabetes have an increased risk of developing pancreatic cancer, diabetes type 2. When we look at this, that increased risk, it has been shown in several studies to be independent of the obesity factor, which is obviously a risk factor for
Sure.
diabetes as well as a risk factor for pancreatic cancer. We have a second issue, though, and that's short-term diabetes. So the long-term diabetes has an increased risk of pancreatic cancer, but it's not such an increased risk that you would go and screen all the millions of people with diabetes to look for pancreatic cancer at random. It would not be cost-effective. Short-term diabetes is another issue because there is a large proportion of patients who are diagnosed with pancreatic cancer within a year or 36 months of the diagnosis, within a year or 36 months of having previously been diagnosed with diabetes. So in other words, they're diagnosed with diabetes, and 6 to 36 months later, they're diagnosed with pancreatic cancer. And you can't see that as causative because usually something that causes a cancer takes years to cause that cancer, not just a couple of years. So diabetes seems to come with pancreatic cancer, and there is some data now suggesting there are peptides that may be responsible that are secreted by the pancreatic cancers or the pancreatic cells that actually lead to this diabetes that's almost a paraneoplastic syndrome. So it is an interesting phenomenon. There's certainly an association and a tight-knit association between pancreatic cancer and diabetes, but how to sort it all out has not been completely understood.
So do these peptide humoral factors cause insulin resistance, or do they inhibit insulin release, or what is suspected to be the mechanism whereby they cause diabetes before the cancer even becomes manifest?
I'm not sure we entirely know that answer. If we do, I don't know that answer. And honestly, I think that's an important factor. So how these peptides act and how they cause this may help us to better understand the disease and may help us to address some of the other syndromes that come with the pancreatic cancer, such as the cancer cachexia syndrome, where the patients lose a lot of weight, lose a lot of muscle mass, and can waste away even while the disease is not necessarily progressing. And so these things, understanding the metabolics that go along with pancreatic cancer, are very important.
So you mentioned we can't just go and screen everybody with type 2 diabetes for cancer of the pancreas, but I know you're active with a number of advocacy boards. You see a tremendous number of patients with cancer of the pancreas. They all have to be concerned about their families and their relatives and all. Which patients are relatives of patients do you advise to be screened? And is there a group of people, not just those of us that are getting old, but is there a group of people who need to be wary and who should be screened for adenocarcinoma of the pancreas?
Well, so there is a group of people who have familial pancreatic cancer. And of course, what we're always concerned about are people who have first-degree relatives with pancreatic cancer. That's mother, brother, father, sister, son, daughter. Certainly, those are the people we're most worried about. The more family members with the pancreatic cancer, the more likely we're to worry about it. We have identified a few syndromes that we can actually screen for that are important. One is called FAMMM, with malignant melanoma, a skin cancer, and atypical moles, as well as pancreatic cancer. We also have the BRCA2, which is a breast cancer gene that not only can be screened for, but may be important in helping to determine the treatment, because patients with BRCA2 mutations may be more sensitive to certain types of anti-cancer agents that might help them to live longer if we're aware of that. So it's important to take a good family history, for the doctors to take a good family history. And then we are lucky enough at comprehensive cancer centers like Vanderbilt University to have a cancer family risk service where we can send the patients there. They can determine the risk and even determine if there's genetic testing that can be done to help the family members determine their risks. Then screening becomes more of an issue, because the screening tests thus far are endoscopic ultrasound and CT scan and have not been proven definitively to be of benefit. When you have a colon cancer in your family and you're screening by doing colonoscopy, you take out a polyp, it's a simple thing. If you find a precancerous lesion in a pancreas, it's a major surgery to remove it. Absolutely. And you could end up with no pancreas, which causes diabetes.
Yeah.
And so there are a lot of issues, and that's the type of thing that needs to go to a major cancer center that has a family risk service, that has the capabilities and the clinic that actually deals with these things. And that's a group of patients that really need to. So anybody with a first-degree family member, especially if they were very young when diagnosed, and very young is anything under the age of 50. I know that 20-year-olds think that's old, but it's young. And the bottom line is, if you have multiple family members with pancreatic cancer, or pancreatic cancer and melanoma, or pancreatic cancer and breast cancer, those types of things need to be really considered.
Right, very good. Well, let's move on and talk a little bit about translational research. We know in a number of solid tumors, melanoma and some non-small cell lung cancers and colon cancer, that there are certain oncologic drivers that have been identified, and in some cases, HER2 positivity in gastric cancer and EGFR mutations in non-small cell lung cancer, these drive the malignancy in a significant percentage of patients. But we haven't seen anything like that identified in cancer of the pancreas, although it's known that there are lots of mutations and deletions and gene rearrangements and this sort of thing. Where are things headed in cancer of the pancreas?
Well, so despite the fact that we haven't identified a driver, we have identified mutations that are more common, that may be helping to drive the pancreatic cancers, that may be helping to make them more resistant. There are a lot of them, and not everybody has all of them. There's one, KRAS, that has not been targeted by any pharmaceutical agent thus far, that stands out among all the others as being the most frequent. Greater than 90% of pancreatic cancer patients have KRAS mutations, depending on whose data you look at.
And are these the same mutations that are seen in colon cancer, codons 12 and 13?
Almost always codon 12. So yes, the answer is it's the same mutation. We think that this is a potentially druggable target, and there actually is a strong movement from the NCI. Dr. Varmus, who leads the NCI, has put together a KRAS team, which we are fortunate enough to have one of the team members at Vanderbilt, because we are building a KRAS inhibitor at Vanderbilt, as are other places, trying to target what is considered the undruggable. That's one major driver, potentially, that may, if targeted, make the tumors more susceptible. But as we start doing this, we may have to divide pancreatic cancer up into multiple diseases. The KRAS mutated, the SMAD4 overexpression, the CDKN2. There are a lot of different mutations. P53 mutated tumors may be more sensitive to new drugs called WEE1 or CHEK1 inhibitors. So we're getting these agents that may have us segregating these patients based on what their mutations are and what their collection of mutations are compared to other patients, so that what we do is we may have divide up pancreatic cancer into 50 or 60 diseases. That creates a problem. It's harder to do clinical trials, but if the impact is greater, dividing them up into smaller groups will be worthwhile and worth the initial investment in finding what group they're in to be able to make a huge difference in their lifespan and their quality of life.
In individual patients, in order to do this testing, is tissue acquisition going to be a significant hindrance?
So yes, tissue acquisition has been one of our greatest problems in pancreatic cancer. Breast cancer, for example, the tissue is very easily accessible. Colon cancer, easily accessible. Not the most pleasant test, but it's easily accessible. Pancreas is way in the back of the abdomen. There are 3 rules in surgery: eat when you can, sleep when you can, and never mess with the pancreas. That's because it's a tender organ. It can go into pancreatitis and get inflamed with a good solid biopsy. So when we biopsy, we have to take it seriously. The nice thing is that we are developing better ways of biopsying. The endoscopic ultrasound, which usually used to do a fine needle aspirate collecting very minimal numbers of cells, can now be done with a bigger needle and get a larger number of cells to be able to do more studies, to be able to find out what the mutations are. There is work being done on collecting circulating tumor cells, so drawing blood and collecting the cancer cells that are circulating in the blood. We'd rather not have to worry about those because that means the cancer can be spreading. And of course, if there are metastases to other organs like the liver, that's an unfortunate event, but the biopsies are easier and safer.
Right. And they're now, I know in lung cancer, they're doing the molecular testing on just FNAs and smaller amounts of tissue than they were able to use before. So advances even in the technology.
Yeah, technological advances have been going leaps and bounds ahead of anything we could ever imagine. The rate at which we're learning how to do things faster, better, and with smaller amounts of tissue and smaller number of cells is amazing. We're working at Vanderbilt with a technique that can stain multiple times the same exact specimen.
Right. And unlike most things in medicine, the DNA sequencing is getting cheaper.
Yes.
So that's a good thing.
We finally have something getting cheaper in medicine.
Absolutely, and there's not many things like that around. So let's talk about some of the abstracts that were presented this afternoon, because I think there were some really interesting things, and we're finally beginning to see some randomized phase 3 trials and randomized phase 2 trials that show some interesting data. There was the JAZPAC trial, and that was an adjuvant trial carried out by the Japanese groups, and they've been able to do huge studies with their favorite drug, S1, which it seems like they treat everything with S1, but especially gastrointestinal cancers. And they did a phase 3 trial in resected patients, highly selected patients, comparing adjuvant gemcitabine and adjuvant S1. And now gemcitabine has been pretty much the standard in this country for a while since the CONCO 001 trial. So remind us a little bit about S1 and how it differs like from capecitabine and what the trial showed.
So there are 3 oral agents in the world, 1 in the United States. Capecitabine is what's called an oral prodrug. It gets metabolized in the body into 5-FU, which is actually itself a prodrug. It's metabolized to active forms that then cause the effect on the DNA and the RNA and lead to the anti-cancer effect. S1 has also a prodrug that gets converted to 5-FU. It has an inhibitor of one of the metabolizing enzymes of 5-FU, DPD, that allows the drug to stay around and become more 5-FU rather than going to inactive metabolites. And it has something that's supposed to inhibit the metabolite that causes the diarrhea, so as to reduce the diarrhea. And that's different from the third drug, which is UFT, which just has an inhibitor of the DPD and the prodrug of 5-FU. So S1 has been tested in the United States in gastric cancer, and S1 has an interesting factor. It is not as well tolerated in the United States and Europe as it is in Japan. Capecitabine actually has that same data. Different doses are applied to different continents, and we think that some of that is based on folate in our diet, but we don't know the whole story.
Right.
What's most important is there hasn't been the same level of activity in S1 in gastric cancer in the United States as there has been in Japan. Pancreatic cancer is not as well studied in the U.S. Is it possible that this is really as great as it looks? Certainly in Japan, it looked fantastic. S1 was better than gemcitabine, which is the standard of care in this country and around most of the globe. S1 will probably be used in Japan. Do we have the same basic genetic background as the Japanese population that might make them more susceptible to oral fluoropyrimidines, S1, capecitabine, UFT, whichever one you talk about? Or is there some other factor? Or would this be just as good a drug in the Western countries with the lower dose that we can tolerate? Because when we take that drug, we get a lot more diarrhea at the same doses as the Japanese use. So that study probably needs to be done in the Western countries to see if this is good in the Western countries. It would not negate the data in Japan. And in the United States, which has a large Asian population, it probably wouldn't negate the data for the Asian populations that have a similar genetic makeup.
Yeah, well, it certainly would seem logical to do a study in the Asian population in this country and a similar study in the Asian population in East Asia to see if there is a difference. I mean, we already know in adenocarcinoma of the lung and in gastric cancer, there are some definite differences between Western populations and East Asian populations. So it's certainly believable that that might be true with pancreas also.
Yeah, and it will be a very complex study because, of course, not every part of the Asian population has picked up the Western diet. But if dietary factors play a role in the risks and benefits of these drugs, then we're going to have big issues because diet's a very hard thing to measure.
Yeah, and there's so many foods that are supplemented.
Right.
You just have to avoid a lot of things.
I believe the buns at McDonald's are supplemented with folic acid.
I wouldn't be surprised.
I'm not 100% sure on that, but I'm fairly confident of it.
Well, there are some very large buns at most McDonald's.
And and there are reasons to do these supplements in the United States because what you worry about is the birth defects from folic acid deficiency. So this is a public health issue, and they addressed it by putting folic acid in almost everything that has grains in it in this country.
Right.
And it's a great move, but may play a different role in this situation.
So let's talk a little bit about locally advanced pancreatic cancer. It's been an area of controversy in the past with the SPEC trials and the intergroup trial here, what the role of radiation is and which agent to combine with radiation. And there was a study from the UK, the SCALLOP trial, looking at capecitabine versus gemcitabine with radiation. And it's sort of a complicated trial, but tell us what they did.
Well, it was a very complex trial where they gave chemotherapy followed by chemoradiation, and the patients were randomly assigned to capecitabine during the radiation or gemcitabine during the radiation. They got capecitabine and gemcitabine combined beforehand.
Right.
And so they all had the same pre-treatment. These days, most people are feeling that if radiation is a part of this regimen, that consolidative radiation after getting some chemotherapy is important in locally advanced disease. The randomization did not suggest that gemcitabine radiation was as good as the capecitabine radiation. And so I think capecitabine and radiation being the standard, one of the standards of care, 5-FU or infusional fluoropyrimidine is the other standard. They're very equivalent, probably, but capecitabine will remain the standard with radiation at the current time until somebody can come up with something better. It did not suggest that further study of gemcitabine plus radiation was worthwhile based on that data. In terms of by itself, chemotherapy with gemcitabine did beat 5FU in the one randomized trial that was performed almost 2 decades ago. But that's where we're at right now, is with radiation, capecitabine may be the better choice. It may be a toxicity issue, although that didn't clearly come out in the data. There may be a lot of other reasons why the gemcitabine is not as effective with radiation. If you look at the preclinical models, probably gemcitabine is most effective if you give it twice a week with radiation, but the doses you can give are minute.
It's such a radiation sensitizer that...
Yes. And it sensitizes the normal tissues as well. 5FU doesn't sensitize normal tissues as much as the gemcitabine does, which plays a big role, although with the IMRTs and the specialized radiation techniques that we can do now, we don't hit as much normal tissue.
Right.
We still hit some.
All right, well, let me ask you about another study. This was a study headed out of Georgetown. And you'd mentioned earlier the incidence of BRCA2 abnormalities in cancer of the pancreas, and this group combined a PARP inhibitor with a FOLFOX regimen, and they based this on the DNA repair defects that are seen in some pancreatic cancers, especially those that have BRCA2 mutations. So we've seen other trials with PARP inhibitors. There are a ton of trials going on. There was a famous breast cancer trial that fell flat on its face in phase 3 after phase 2 looked good. But the investigator told me at the poster that this is an actual PARP inhibitor, this ABT888. What were your impressions of this study, and do you feel that there is a significant future for PARP inhibitors in cancer of the pancreas?
So first, with regards to the ABT888, I have to disclose I'm an investigator on a separate trial for that drug. It is a real PARP inhibitor. There are some questions about the agent in the breast cancer study as to how good a PARP inhibitor that agent turned out to be. 888, there's no question. It inhibits PARP. PARP, when overactive, so to speak, in a patient who's got deficiencies in repair of their DNA, is a great target. And BRCA2 patients, Fanconi's patients, PALB2 patients, all potentially have these defects in DNA repair. That's part of the reason why they're susceptible to developing these cancers in theory. And therefore, giving these PARP inhibitors to these patients seems to be very active. And in fact, when you give real PARP inhibitors to breast cancer, ovarian cancer patients, that's exactly what you're seeing. This was a great study. They did see some very good effects in some patients who do have, who had known BRCA2. And in addition, the PARP inhibitors look synergistic with platinum. So the FOLFOX regimen was a good choice of regimen to use.
Because of its DNA damaging qualities.
It's DNA damaging, and the other thing is that the repair mechanisms have a much tougher time with oxaliplatin than the cisplatin and carboplatin, because oxaliplatin is a much larger moiety. And the diaminocyclohexane ring attached to the oxaliplatin is much harder for the DNA repair mechanisms to pluck out once it's intercalated itself into the DNA. So once it's bound to the DNA, it's stuck there.
And there was some mention in a case presentation today about the use of mitomycin C in someone who had the PALB2 abnormality. Are we likely to see that drug make a comeback in pancreatic cancer in patients who have DNA repair defects?
Well, so Hopkins has been talking about this patient for a long time, but it's based on preclinical data that I believe was part of their SPORE grant that truly showed that these patients would be more susceptible to mitomycin, which again is a DNA damaging agent, an antibiotic DNA damaging agent. And it does look like mitomycin will be an effective agent in this small group of patients, but very important group of patients. Again, subgrouping the patients out. Well, mitomycin is being studied on a clinical trial right now for these patients, and I believe still going on in Hopkins. And there are also some PARP studies going on at Memorial Sloan Kettering to look further at this question of PARP inhibition in these patients. So I think this small group of patients that's very real, that has these various mechanisms, may account for up to 5% of pancreatic cancers. We may have much more effective therapies. That patient at Hopkins, they keep talking about them, but it's been 7 years.
Yeah.
7 years, and the patient's still healthy with a very otherwise deadly disease. So one has to say, wow.
Yeah, that's and I know Eileen O'Reilly at Memorial's been doing work in this area also. So let's go on to one of the final abstracts from today, and this was sort of stuck in at the end. It wasn't originally on the schedule, but I think they felt compelled to have Dan Von Hoff present the data from the MPACT trial. So tell us about that, and this is something people have been waiting for a while.
So this was a late-breaking abstract, and that's why it was kind of thrown in later, is my guess. I'm not involved in the program committee, but it was thrown in. It wasn't on the program, but a late-breaking abstract, very exciting news. It was released as a press release in December that gemcitabine plus nab-paclitaxel, or nanoparticle albumin-bound paclitaxel, met its endpoints for beating gemcitabine alone. So the combination of gemcitabine plus nab-paclitaxel beat gemcitabine alone, which is great.
And there have been so many gem plus drug X trials that have fallen flat on their face with overall survival forever at 6 months. This looked pretty exciting.
Yeah, it was exciting. It was not dramatic, but it was exciting. And partially because in the last 2 decades, we've had 4, count them, 4 positive randomized trials. The one that gemcitabine beat 5-FU on, only 126 patients. And 5-FU was given in the least effective method possible.
Yeah.
We have gemcitabine versus gemcitabine plus erlotinib. Not really a good scientific rationale, not really a great outcome, but it was a positive trial, and it was a real positive trial.
You weren't impressed by that 13-day increase in survival?
Well, I don't pay attention to the days. I pay attention to the hazard ratio of 0.81, which is better than things like gemcitabine, capecitabine, which have borderline statistics and things like that. But still, when you look at that 13 days, it does kind of depress you. Even if you take it as the hazard ratio and ignore the fact that the curves come together, it still looks like it's probably a month difference. Not enough. Well, and then we had FOLFIRINOX, which gave us a whole new regimen. Beat gemcitabine, but it's a toxic regimen. Nab-paclitaxel looks tolerable. Now, the thing is that there were some sepsis, there was some neutropenic fevers, there were some real toxicities on this, but it looks much more tolerable comparing across trials, which is dangerous, than the FOLFIRINOX did. The populations looked similar, but the populations were distributed across a much greater part of the world on the nab-paclitaxel gemcitabine study than on the FOLFIRINOX study.
And the dose of nab-paclitaxel was a little bit lower than we've seen in some of the trials in breast cancer and lung cancer. They're usually 150 milligrams per meter squared or higher. So this was 125.
Well, I think that's the important part of this. So there was data that suggested that the spark that's overexpressed in the stroma of pancreatic cancer would suck the nab-paclitaxel in, basically, and hold it there in the tumor, in the stroma, which would be very exciting and would increase theoretically the exposure to the nab-paclitaxel. There was data from Manny Hidalgo's lab that there was stromal disruption from the nab-paclitaxel, and stroma is part of the reason why the pancreatic cancers are resistant. And there's data from Dave Tuveson's lab that suggests that the nab-paclitaxel actually inhibits something called cytidine deaminase, which metabolizes gemcitabine to inactive forms. So suddenly you have a lot of things that may be potentially causing gemcitabine and nab-paclitaxel to have scientific rationale, as opposed to most of the gemcitabine versus gemcitabine plus your drug here studies, where they were just adding it to the FDA standard for the sake of adding it, not because there was a rationale. This had rationale. This had a phase 1-2 study, which had very good survivals, but of course highly selected patients, so not surprising that we didn't see the results that they saw in the phase 2, or the phase 1-2 really. But we saw results that were positive. Now, it was not a miracle drug. The median survival difference is 1.8 months, but again, it's the hazard ratio, which is about 0.7. which is good. Not outstanding, but very good, and it's certainly the first movement forward that we've really seen with a gemcitabine-based regimen, and it gives us an alternative to the FOLFIRINOX regimen.
So for patients who aren't quite up to the rigors of FOLFIRINOX, this might be a reasonable regimen.
And while we saw FOLFIRINOX seems to have a much better survival, because these populations have differences and it's cross-trials, we don't know that the two aren't similar in their overall efficacy, but there's a possibility that they're not identical. And we just don't know that right now. And I don't know if we'll ever know that. I'm not sure if a FOLFIRINOX versus gemcitabine nab-paclitaxel study is A, worth it, and B, will ever get done.
Well, there was another drug lurking in the background that did not get presented, except as a poster presented at ESMO, this threshold 302 drug that there's some interesting data that looks like there's dose dependency, and this hypoxic activated alkylating agent may have some potential benefit in combination with gemcitabine also. So I guess we'll just have to wait to see for more follow-up on that.
So the
study.
TH302, which is activated in hypoxic areas, and pancreatic cancer is boatloads of hypoxic territory, it theoretically gets the gemcitabine to the less hypoxic areas and the TH302 into the hypoxic areas, and you've got treatment in both areas. And they did meet their endpoints, or their threshold. It's the company's name, but their threshold, the threshold for moving forward, and my understanding is they're moving forward with a randomized phase 3 trial to look further. So we'll have to see how that goes.
Yeah.
It's been presented enough that I understand why it was a poster this time, because it's been out there for a while. I think the data is interesting and intriguing. How they're going to do the phase 3 trial, because this is an agent that now you've got a gemcitabine versus gemcitabine plus their threshold drug in an era when gemcitabine nab-paclitaxel is better.
That's right.
And so how they'll work that out is a decision that the companies need to make. They've partnered with Merck KGaA in Europe to work together on this trial, and I look forward to seeing how it comes out.
It'll be interesting. All right. Well, let me finally ask you, the final session this afternoon was on hepatocellular carcinoma, and they talked about transplantation, liver transplantation. It doesn't seem like there are that many patients who are eligible for that. But is there a change in the some of the original criteria, the Milan criteria? Is there going to be an expanding number of patients who may be eligible for transplant?
So that was exciting to me. I mean, I had not known about this. I don't follow the transplant data enough. It turns out that years ago, the group in Milan did a painstakingly careful evaluation of who benefited from transplant with liver cancer and found the criteria, particularly a single tumor less than 5 centimeters or 3 tumors with none greater than 3 centimeters, that would be potentially benefit from a liver transplant. And these patients, after liver transplant, have an 80% 5-year survival in that range.
Pretty impressive.
It's very impressive. But the patients beyond that didn't qualify. And yet we've been developing techniques with radiotheraspheres and radioactive spheres or beads and drug-eluting beads and a variety of other embolization materials, RFA, tight radiation such as stereotactic radiation or the gamma knife or proton beam or any other trendy name they've come up with for their radiation technology. And all these things can shrink those tumors down and make them have the potential to bring them into the Milan criteria. So if you can do that, does that expand the patients who could get liver transplant? In fact, actually, the data that was presented, all retrospective, but very intriguing, suggested yes, that there are a group of patients, they also have criteria for that, that can have their tumors shrunk. If they can maintain the control within the Milan criteria for 3 months, they can get transplanted, and the numbers range, but numbers of 4-year survivals of 80% are there.
Right.
And very encouraging. Now, the problem, of course, is that doesn't tell you that the pool of livers available for all the different diseases is going to increase. And so we would increase the number of people looking for a very limited resource.
Supply of livers,
and that's going to be a problem, and it's going to need to be a public policy problem where we say, you know, it's worthwhile to be a liver donor. We don't want you to die, But if you do, you may be able to help
Yeah.
somebody else. And it's a horrible way of looking at life. And nobody who gets a transplant doesn't recognize the value that somebody else has provided them and the horrible sacrifice that they unfortunately made. And if people start wearing more motorcycle helmets, we'll have even less donors. But the bottom line is that we'll need more donors. We'll need to find ways to increase the livers available or increase the use of the livers that we have, splitting them, if that's a possibility. Whatever we can do, if we can increase the number of people who could benefit from liver transplant, God knows it's a wonderful way of fixing this disease.
I have 2 friends who've had heart transplants, and one of those was like 15 years ago, and he's doing great. The other is just maybe 3 years ago, but is also doing well. So, I mean, those donors have through their generosity, have kept these 2 guys alive for a number of years, which is an amazing accomplishment.
That's true. You know, my nurse practitioner is actually one of the liver transplant. She worked in the liver transplant team for years. And the other day I had a patient come by, a new patient come by, and his brother-in-law is one of our liver transplant patients for HCC. Brother-in-law was
amazing.
7 years or something like that. I don't even know how long, but a long time. And they got to reunite in my clinic.
That's great. Jordan, thank you so much. This
Thank
has been
you.
really good, really interesting. These more focused symposium are, I think, a great way to learn, and I think get a lot more out of this than the main ASCO meeting. So I'm so glad you could join us and discuss some of the presentation from today.
Well, thank you for inviting me. I agree. I love these targeted meetings where you can attend everything and not feel stressed for having missed so much.
Oh, I know.
But, of course, I still love the main ASCO as well.
Absolutely.
Okay.
Absolutely. All right. Thanks
Thank
so
you.
much. And thanks to all of you for watching this segment of Best of the Day from the 2013 ASCO Gastrointestinal Cancer Symposium. There will be much more tomorrow on colorectal cancer, so be sure to check back with us. Thanks again.